Psoriasis flare secondary to Koebner phenomenon in the setting of atrial fibrillation monitoring, itching to find the cause. Psoriasis is a common, recurrent, chronic inflammatory skin disease characterized by silvery white scaly plaques on erythematous bases located primarily on the scalp and extensor extremities. According to the 2020 U.S. Census, psoriasis affects approximately 7.5 million U.S. adults, equivalent to about 3.2% of the population. Patients are negatively affected both physically and psychosocially, and more studies reveal that psoriasis extends beyond just the skin and the joints and is more associated with increased risk of cardiovascular diseases, including ischemic stroke and atrial fibrillation. Current therapies include topical corticosteroids, TAR therapy, and biologic therapy. Koebner phenomenon, also known as isomorphic response, describes the appearance of new lesions secondary to trauma on previously unaffected skin. We present an interesting case of psoriform dermatitis secondary to Koebner phenomenon in a patient with history of atrial fibrillation and severe psoriasis, appearing on the areas where electrocardiogram leads were attached a few days before her follow-up psoriasis appointment. Here, a 47-year-old female with over a 10-year history of palmoplantar psoriasis presents for a follow-up visit. Her psoriasis was previously well controlled with topical corticosteroids and biologic therapy. Past medical history is significant for atrial fibrillation. 3 days prior to presentation, the patient underwent routine EKG monitoring, after which she then developed itching of her chest, right upper extremity, and right lower extremity, curiously located and confined to where the EKG leads were placed. The patient complained that these lesions were extremely itchy and disturbed her sleep. She did not apply any topicals for relief of the pruritus. She denies any change in detergents or hygienic products. Physical examination showed scaly, erythematous plaques with overlying excoriation, consistent with plaque psoriasis. Given the appearance of the lesions and medical history, EKG-led induced psoriasis was the primary differential diagnosis. However, other differentials, including contact dermatitis and allergic dermatitis, were also considered. She was encouraged to apply topical clobetasol and mupirocin once daily to the lesions. Follow-up one clinic after her visit revealed a complete resolution. Photos were taken at the time of visit with patient consent, and the photos demonstrate eczematous plaques on erythematous bases on the chest, distal right forearm, and distal right thigh. Given the prevalence of cardiovascular disease amongst psoriasis patients, it is important for physicians to be aware of EKG-led induced psoriasis and those with medical history of psoriasis. Within the history, primary complaint will be extensive pruritus. Physical exam findings will include confined, nummular, eczematous plaques with erythema on areas of the body where EKG leads are placed, including the chest and upper and lower extremities, contributing to the Koebner phenomenon. With this awareness, physicians can suspect EKG-led induced psoriasis in psoriatic patients who present with a flare within a few days of having an EKG performed. Physicians can also anticipate a potential flare-up after a psoriatic patient has an EKG. EKG-led induced psoriasis can be empirically treated with a topical corticosteroid and mupirocin if secondary infection is suspected. No biopsy of the lesions are needed at the time of flare. We stress the importance of recognizing and adequately treating EKG-induced psoriasis to increase quality of life for our patients. Thank you.